Question 1. A nurse is caring for a patient admitted with a severe traumatic brain injury who has an external ventricular drain, EVD, in place. The nurse notes the intracranial pressure, ICP, reading is 22 mm of mercury with a P2 wave consistently higher than the P1 wave on the ICP waveform monitor. The patient's mean arterial pressure, MAP, is 85 mm of mercury. Which nursing intervention is most appropriate based on these findings? A. Administer a prescribed osmotic diuretic, such as mannitol. B. Place the patient in Trendelenburg position to promote venous return. C. Increase the rate of the patient's continuous intravenous sedation. D. Lower the EVD drainage bag to facilitate more cerebrospinal fluid, CSF, outflow. Answer. A. Administer a prescribed osmotic diuretic, such as mannitol. This question tests your understanding of ICP waveform interpretation and management of increased ICP. The key clues are an ICP of 22 mm of mercury, elevated above the normal 5 to 15 mm of mercury, and a P2 wave higher than P1, which indicates decreased intracranial compliance and impending decompensation. Administering an osmotic diuretic like mannitol helps to reduce cerebral edema by drawing fluid from brain tissue into the vascular space, thereby lowering ICP. Placing the patient in Trendelenburg position would increase ICP. Increasing sedation without addressing the underlying pressure is insufficient, and lowering the EVD bag would increase CSF drainage too rapidly, potentially causing complications. When intracranial compliance is poor, timely intervention to reduce ICP is crucial to prevent further neurological damage. Here's an easy way to remember. An elevated ICP with a P2-P1 waveform signals an urgent need for interventions to reduce brain swelling. Question 2. A patient presents to the emergency department with sudden onset right-sided weakness, facial droop, and expressive aphasia. A non-contrast computed tomography, CT, scan of the brain is negative for hemorrhage. The patient's last known normal was 2 hours ago. Which of the following is an absolute contraindication to administering intravenous recombinant tissue plasminogen activator, TPA, for this patient? A. Blood pressure of 170/95 mmHg. B. Current use of aspirin daily. C. History of a minor stroke 3 months ago. D. Platelet count of 85,000/L. Answer, D. Platelet count of 85,000/L. This question assesses your knowledge of the contraindications for TPA administration in acute ischemic stroke. The crucial keyword is absolute contraindication, meaning a condition that completely rules out the medication due to high risk. A platelet count below 100,000/L is an absolute contraindication for TPA because it significantly increases the risk of symptomatic intracranial hemorrhage. While a blood pressure of 170/95 mmHg would need to be managed before TPA, goal 185/110 mmHg, it is not an absolute contraindication if it can be controlled, and a history of a minor stroke 3 months ago or daily aspirin use are not absolute contraindications within the current guidelines. Remember, TPA is a powerful thrombolytic, and patient safety from bleeding risks is paramount. Question 3. A patient with a T6 spinal cord injury suddenly develops a severe headache, blurred vision, diaphoresis above the level of injury, and a blood pressure of 200/100 mmHg. The nurse notes goosebumps on the patient's arms. What is the nurse's priority action? A. Administer a rapid-acting antihypertensive medication. B. Elevate the head of the bed to 90 degrees. C. Palpate the patient's bladder for distension. D. Document the findings and continue to monitor. Answer, C. Palpate the patient's bladder for distension. This question focuses on the immediate management of autonomic dysreflexia, a life-threatening emergency in patients with spinal cord injuries at or above T6. The key clues are the sudden severe headache, hypertension, diaphoresis, and goosebumps, which are classic signs of this condition. The priority action is to identify and remove the noxious stimulus below the level of injury, with bladder distension being the most common cause. While administering an antihypertensive might be necessary if the blood pressure remains elevated after identifying the cause, and elevating the head of the bed is also an initial measure to reduce blood pressure, finding the cause is the priority. Always begin by looking for the trigger, such as a full bladder, fecal impaction, or tight clothing. Question 4. A patient is admitted to the critical care unit following a motor vehicle accident. On assessment, the patient opens their eyes only to pain, makes incomprehensible sounds, and exhibits decorticate posturing to painful stimuli. What is this patient's Glasgow Coma Scale, GCS, score? A. 3. B. 6. C. 8. D. 10. Answer, B. 6. This question tests your ability to accurately calculate a Glasgow Coma Scale, GCS, score, a fundamental neurological assessment tool. The GCS evaluates eye opening, verbal response, and motor response. For opening eyes only to pain, the score is 2. For making incomprehensible sounds, the verbal score is 2. For exhibiting decorticate posturing, flexion, to painful stimuli, the motor score is 3. Adding these scores together, 2 plus 2 plus 2, results in a total GCS of 6. A score of 8 or less typically indicates severe brain injury and often necessitates intubation and aggressive management. Practicing GCS scoring is vital for all critical care nurses. Question 5. A 68-year-old patient with a history of hypertension and diabetes is admitted with an ischemic stroke. On the second day, the patient develops a sudden onset of a severe headache, nausea, and photophobia. The nurse notes a new nuchal rigidity during the assessment. These findings are most suggestive of which complication? A. Seizure activity. B. Reocclusion of the affected vessel. C. Hemorrhagic conversion of the ischemic stroke. D. New onset migraine headache. Answer, C. Hemorrhagic conversion of the ischemic stroke. This question assesses your ability to recognize the signs and symptoms of hemorrhagic conversion, a serious complication of ischemic stroke, especially in patients with comorbidities like hypertension and diabetes. The key clues are the sudden onset of severe headache, nausea, photophobia, and the new finding of nuchal rigidity, which strongly suggest meningeal irritation often caused by blood in the subarachnoid space due to a bleeding event. While seizures can occur post-stroke, these specific signs point more directly to hemorrhage. Reocclusion typically presents with worsening neurological deficits, not meningeal signs. New onset migraine is less likely given the patient's history and acute neurological event. Recognizing these changes promptly is critical for immediate diagnostic imaging and intervention. Question 6. A patient with myasthenia gravis is admitted to the ICU with profound muscle weakness and respiratory distress. The physician orders an edrophonium, tensilin, test. After administration, the patient's muscle weakness significantly worsens, and respiratory effort further declines. What is the most likely cause of this patient's symptoms? A. Myasthenic crisis. B. Cholinergic crisis. C. Guillain-Barré syndrome. D. Status epilepticus. Answer, B. Cholinergic crisis. This question tests your understanding of the Tensilin test's diagnostic use in differentiating between a myasthenic crisis and a cholinergic crisis. Edrophonium, an anticholinesterase inhibitor, temporarily increases acetylcholine levels. In a myasthenic crisis, there's insufficient acetylcholine, so weakness would improve with Tensilin. However, if the weakness worsens and respiratory effort declines after Tensilin, it indicates an excess of acetylcholine, leading to a cholinergic crisis. Guillain-Barré syndrome is an autoimmune disorder that causes ascending paralysis and is not directly related to acetylcholine levels, and status epilepticus is prolonged seizure activity. Understanding the paradoxical response to Tensilin is crucial for correct diagnosis and treatment in myasthenia gravis patients. Question 7. A critical care nurse is performing a neurological assessment on a patient with suspected brain death. Which of the following findings is inconsistent with a diagnosis of brain death? A. Absence of brainstem reflexes, including pupillary, corneal, oculocephalic, oculovestibular, and gag reflexes. B. A positive apnea test with an increase in PaCO2 to 65 mm of mercury and no respiratory effort. C. Deep tendon reflexes elicited in the lower extremities. D. Flat electroencephalogram, EEG, demonstrating no electrical activity. Answer, C. Deep tendon reflexes elicited in the lower extremities. This question challenges your knowledge of the comprehensive criteria for brain death. The core concept is that brain death involves irreversible cessation of all functions of the entire brain, including the brainstem. While a flat EEG and absent brainstem reflexes are consistent with brain death, the presence of deep tendon reflexes, even in the lower extremities, can be spinal reflexes, which do not originate in the brain and thus do not rule out brain death. A positive apnea test, no respiratory effort despite adequate CO2 stimulus, is also a key criterion. The absence of specific brainstem reflexes is critical, but spinal reflexes are not part of the brain death assessment. Question 8. A patient recovering from a subarachnoid hemorrhage, SAH, is receiving nimodipine and remains on strict bed rest. On hospital day 7, the nurse notes the patient is increasingly lethargic and disoriented, with new onset left-sided weakness. What complication should the nurse immediately suspect? A. Rebleeding. B. Hydrocephalus. C. Vasospasm. D. Seizure activity. Answer, C. Vasospasm. This question focuses on recognizing a critical delayed complication of subarachnoid hemorrhage. The keywords are hospital day 7, increasingly lethargic and disoriented, and new onset left-sided weakness, which collectively point to cerebral vasospasm. Vasospasm, the narrowing of cerebral blood vessels, typically occurs 3 to 14 days after SAH, leading to delayed cerebral ischemia and new neurological deficits. While rebleeding and hydrocephalus are also SAH complications, the timing and specific neurological changes strongly suggest vasospasm, which is often managed with triple H therapy, hypertension, hypervolemia, hemodilution, and nimodipine. Prompt recognition of vasospasm is crucial for preventing permanent neurological damage. Question 9. A patient with a severe traumatic brain injury develops an abrupt onset of polyuria, urine output of 400 milliliters per hour for 2 consecutive hours, and a serum sodium of 155 milliequivalent/L. The urine-specific gravity is 1,002. Which of the following conditions do these findings most strongly suggest? A. Syndrome of inappropriate antidiuretic hormone, SIAD. B. Cerebral salt wasting, CSW. C. Diabetes insipidus, DI. D. Adrenal insufficiency. Answer C. Diabetes insipidus, DI. This question tests your ability to differentiate endocrine complications following neurological injury, specifically diabetes insipidus, DI. The key clues are abrupt polyuria, excessive urination, hypernatremia, high serum sodium, and a very low urine-specific gravity, indicating dilute urine. This constellation of symptoms is characteristic of central DI, where the pituitary gland fails to produce or release antidiuretic hormone, ADH, leading to excessive free water loss. SIAD presents with oliguria, low urine output, and hyponatremia due to too much ADH. CSW involves sodium wasting, and adrenal insufficiency has different electrolyte disturbances. Prompt recognition and treatment with desmopressin, DAP, are critical to prevent severe dehydration and electrolyte imbalances. Question 10. A patient sustained a spinal cord injury at the C5 level. When educating the patient and family about potential long-term respiratory challenges, which statement by the nurse is most accurate? A. You will likely be ventilator dependent for the rest of your life. B. You may require assistance with coughing and deep breathing exercises. C. Your diaphragm will function normally, but intercostal muscles will be impaired. D. Spontaneous breathing will be impossible due to complete phrenic nerve paralysis. Answer B. You may require assistance with coughing and deep breathing exercises. This question assesses your knowledge of respiratory compromise in patients with cervical spinal cord injuries. A C5 spinal cord injury affects the innervation of the diaphragm, C3-C5, but typically spares enough function to allow some spontaneous breathing, though often compromised. The intercostal and abdominal muscles, crucial for effective coughing and deep breathing, are often significantly impaired. Therefore, the patient will likely need assistance with airway clearance techniques, such as assisted coughing, rather than being fully ventilator dependent. Complete phrenic nerve paralysis is more common with injuries at C3 or higher. It's important to understand the varying levels of respiratory impact based on the SCI level. Question 11. A nurse is assessing a patient with a suspected brainstem lesion. When testing cranial nerve 9, glossopharyngeal, and X, vagus, which of the following findings would be most indicative of dysfunction? A. Asymmetrical facial movements. B. Absence of a gag reflex. C. Inability to track objects with the eyes. D. Unilateral pupil dilation. Answer B. Absence of a gag reflex. This question tests your knowledge of cranial nerve assessment, specifically for cranial nerves 9, glossopharyngeal, and X, vagus. These two nerves are responsible for the sensory and motor components of the gag reflex, as well as swallowing and phonation. An absent gag reflex is a direct and critical indicator of dysfunction of these nerves, which are important for airway protection. Asymmetrical facial movements relate to cranial nerve 7, facial. Inability to track objects relates to cranial nerves 3, 4, and 6, oculomotor, trochlear, abducens, and unilateral pupil dilation relates primarily to cranial nerve 3, oculomotor, compression. Always prioritize assessments that directly target the function of the specific nerves in question. Question 12. A patient with severe increased intracranial pressure, ICP, is being managed with mechanical ventilation. Which arterial blood gas, ABG, finding would the nurse aim for to help manage the ICP? A. pH 7, 25, PaCO 2 50 mm of mercury, PaO 2 80 mm of mercury. B. pH 7, 38, PaCO 2 30 mm of mercury, PaO 2 95 mm of mercury. C. pH 7, 48, PaCO 2 30 mm of mercury, PaO 2 120 mm of mercury. D. pH 7, 30, POCO 2 45 mm of mercury, POW 2 60 mm of mercury. Answer B. pH 7, 38, POCO 2 30 mm of mercury, POW 2 95 mm of mercury. This question focuses on the ventilatory management goals for a patient with increased ICP. The key concept is that careful manipulation of POCO 2 can influence cerebral blood flow. Mild hyperventilation, maintaining POCO 2 between 30 to 35 mm of mercury, causes cerebral vasoconstriction, which can temporarily reduce cerebral blood volume and thus ICP. A POW 2 of 95 mm of mercury ensures adequate oxygenation, which is also critical for the injured brain. The other options either show respiratory acidosis, high POCO 2, which causes cerebral vasodilation and increases ICP, or too low POW 2, or excessive hyperventilation that could compromise cerebral perfusion. Remember, maintaining normoxia and mild hypocapnia is often the goal in managing ICP. Question 13. A patient admitted with suspected bacterial meningitis undergoes a lumbar puncture. The nurse should anticipate which cerebrospinal fluid, CSF, findings if bacterial meningitis is confirmed? A. Elevated protein, decreased glucose, clear appearance. B. Decreased protein, elevated glucose, cloudy appearance. C. Elevated protein, decreased glucose, cloudy appearance. D. Normal protein, normal glucose, clear appearance. Answer C. Elevated protein, decreased glucose, cloudy appearance. This question tests your understanding of characteristic CSF findings in bacterial meningitis. The key is to remember how bacterial infection alters CSF components. Bacteria consume glucose, leading to decreased CSF glucose levels. The inflammatory response and bacterial presence increase protein content, and the accumulation of white blood cells, especially neutrophils, and bacteria makes the CSF appear cloudy or turbid. Viral meningitis typically presents with elevated protein and normal glucose, but the CSF is usually clear. Recognizing these specific CSF abnormalities is crucial for distinguishing bacterial from viral meningitis and guiding appropriate antibiotic therapy. Question 14. A patient with a severe traumatic brain injury develops hypotension, MAP 55 mm of mercury, and bradycardia, heart rate 45 bpm. Despite fluid resuscitation, the blood pressure remains low. The patient's skin is warm and dry. What type of shock is this patient most likely experiencing? A. Hypovolemic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Septic shock. Answer C. Neurogenic shock. This question focuses on recognizing neurogenic shock, a distributive shock that can occur following severe central nervous system injury, particularly to the spinal cord but also sometimes with TBI. The critical clues are hypotension and bradycardia, despite adequate fluid resuscitation, along with warm, dry skin, indicating peripheral vasodilation rather than compensatory vasoconstriction. This clinical picture is caused by the disruption of the sympathetic nervous system, leading to a loss of vasomotor tone. Hypovolemic shock would typically present with tachycardia and cool, clammy skin. Cardiogenic and septic shock have different underlying mechanisms and clinical presentations. Understanding the unique hemodynamic profile of neurogenic shock is vital for its specific management. Question 15. A 75-year-old patient with a history of hypertension is admitted to the ICU after a sudden loss of consciousness. A CT scan reveals a large intracerebral hemorrhage. The patient's pupils are fixed and dilated, and there is no response to painful stimuli. Which immediate intervention should the nurse anticipate? A. Administration of intravenous TPA. B. Preparation for emergent craniotomy. C. Initiation of Triple H therapy. D. Administration of a vasopressor to maintain blood pressure. Answer: B. Preparation for emergent craniotomy. This question tests your understanding of acute management for severe intracerebral hemorrhage. The key findings of a large intracerebral hemorrhage coupled with fixed and dilated pupils and no response to painful stimuli indicate severe neurological deterioration and likely transtentorial herniation. In such cases, surgical evacuation of the hematoma via emergent craniotomy is often the only potentially life-saving intervention to relieve mass effect and prevent further brainstem compression. Administering TPA is contraindicated in hemorrhage. Triple H therapy is for vasospasm after SAH, and while blood pressure management is important, vasopressors are not the immediate priority for this acute mass effect. Immediate neurosurgical consultation is crucial. Question 16. A patient with a ventriculoperitoneal (VP) shunt for hydrocephalus presents to the emergency department with a headache, nausea, vomiting, and lethargy. The nurse notes papilledema on fundoscopic examination. These findings are most suggestive of A. Shunt malfunction or obstruction. B. Meningitis. C. Migraine headache. D. Normal shunt function. Answer: A. Shunt malfunction or obstruction. This question assesses your ability to recognize the signs and symptoms of VP shunt malfunction or obstruction. The classic triad of headache, nausea, and vomiting, combined with lethargy and papilledema, swelling of the optic nerve (HD), are all indicators of increased intracranial pressure, ICP. In a patient with a VP shunt, these symptoms strongly suggest that the shunt is no longer effectively draining cerebrospinal fluid, leading to a buildup and increased ICP. While meningitis can cause headache and vomiting, papilledema is more directly linked to ICP. Migraines do not typically cause papilledema. Prompt imaging and neurosurgical consultation are necessary for suspected shunt malfunction. Question 17. A patient with Guillain-Barré syndrome, GBS, is admitted to the ICU. The nurse identifies the most critical assessment to monitor closely is A. Deep tendon reflexes. B. Bowel sounds. C. Respiratory effort and vital capacity. D. Skin integrity. Answer: C. Respiratory effort and vital capacity. This question highlights the most life-threatening complication in Guillain-Barré syndrome, GBS. GBS is an ascending paralysis, meaning muscle weakness often starts in the lower extremities and progresses upwards. The most critical concern in GBS is respiratory muscle paralysis, which can lead to respiratory failure requiring mechanical ventilation. Therefore, continuously monitoring respiratory effort, rate, depth, and serial vital capacity measurements is paramount to detect impending respiratory distress. While deep tendon reflexes will be diminished or absent, and bowel sounds or skin integrity are important, they do not pose the immediate threat to life that respiratory compromise does. Question 18. Following a supratentorial craniotomy, a patient develops clear fluid leaking from the incision site. The fluid tests positive for glucose. What is the nurse's priority action? A. Apply a sterile dressing and reinforce with tape. B. Elevate the head of the bed to 45 degrees. C. Notify the neurosurgeon immediately. D. Document the findings and continue to monitor for changes. Answer: C. Notify the neurosurgeon immediately. This question tests your recognition and immediate management of a serious post-craniotomy complication, cerebrospinal fluid, CSF, leak. The key clue is clear fluid leaking from the incision site that tests positive for glucose, which is characteristic of CSF. A CSF leak increases the risk of meningitis and needs immediate attention from the neurosurgeon. While applying a sterile dressing is part of the initial response, the priority is to inform the surgeon for evaluation and management, which may include CSF diversion or surgical repair. Elevating the head of the bed might be part of post-op care but doesn't address the leak itself, and simply monitoring is insufficient for this urgent finding. Question 19. A critical care nurse is performing an oculovestibular reflex, caloric reflex, test on an unconscious patient. The nurse irrigates the right ear with cold water, and the patient's eyes slowly deviate towards the right ear, then slowly return to midline. How should the nurse interpret this finding? A. Brainstem dysfunction. B. Intact brainstem function. C. Cerebellar dysfunction. D. Cortical dysfunction. Answer B. Intact brainstem function. This question assesses your understanding of brainstem reflex testing, specifically the oculovestibular reflex, also known as the caloric reflex test. When cold water is instilled into the ear of a patient with an intact brainstem, the eyes will slowly deviate towards the irrigated ear, tonic deviation, then slowly return to the midline. This movement confirms the integrity of the brainstem pathways responsible for eye movements. Absent or disconjugate eye movements would indicate brainstem dysfunction. Cerebellar and cortical dysfunction do not directly manifest this way in this specific reflex test. This reflex is crucial for assessing brainstem integrity in unconscious patients. Question 20. A patient admitted after a fall directly onto the back of the head exhibits ecchymosis over the mastoid process, Battle's sign, and clear fluid draining from the nose that tests positive for glucose. These findings are most indicative of A. Concussion. B. Epidural hematoma. C. Basilar skull fracture. D. Spinal cord injury. Answer C. Basilar skull fracture. This question tests your ability to identify classic signs of a basilar skull fracture. The key clues are Battle's sign, ecchymosis over the mastoid process, and clear, glucose-positive fluid draining from the nose, which indicates a cerebrospinal fluid, CSF, leak, rhinorrhea. These signs, especially in combination with a fall to the back of the head, are highly suggestive of a fracture at the base of the skull. A concussion is a milder TBI without these specific signs. An epidural hematoma typically presents with a lucid interval and then rapid deterioration, and a spinal cord injury would have different neurological deficits. Recognizing these distinct signs is vital for prompt diagnosis and preventing complications like meningitis. Question 21. A patient with severe cerebral edema due to an acute stroke is receiving a continuous infusion of hypertonic saline. Which laboratory value is the most important for the nurse to monitor to prevent complications? A. Serum potassium. B. Blood glucose. C. Serum sodium. D. Serum creatinine. Answer C. Serum sodium. This question focuses on the safe administration and monitoring of hypertonic saline, a common treatment for cerebral edema. Hypertonic saline works by creating an osmotic gradient that draws water out of brain cells and into the intravascular space, thereby reducing brain swelling. The most critical lab value to monitor is serum sodium, as rapid increases or excessively high levels can lead to central pontine myelinolysis, a severe neurological disorder. While other electrolytes and kidney function are important, sodium is directly affected and monitored most closely to ensure the therapy's safety and effectiveness. Close monitoring helps ensure optimal therapeutic effect while preventing dangerous side effects. Question 22. A patient with a C4 spinal cord injury develops a sudden drop in blood pressure, BP 70/40 mmHg, heart rate, HR 48 BPM, and a normal body temperature, with warm and flushed skin. The nurse knows these findings indicate which type of shock? A. Cardiogenic shock. B. Hypovolemic shock. C. Distributive shock, neurogenic. D. Obstructive shock. Answer, C. Distributive shock, neurogenic. This question assesses your ability to identify neurogenic shock, a specific type of distributive shock that results from a severe spinal cord injury, particularly at or above T6. The classic triad of symptoms for neurogenic shock includes hypotension, bradycardia, and normothermia or poikilothermia, inability to maintain body temperature, often with warm and dry skin due to loss of sympathetic tone below the level of injury. Unlike other forms of shock, the heart rate does not increase to compensate for low blood pressure because the sympathetic nervous system is disrupted. Recognizing this unique presentation is crucial for appropriate treatment, which involves managing the bradycardia and hypotension with fluids and vasopressors if needed. Question 23. A 60-year-old patient presents with a sudden onset of the worst headache of my life, accompanied by neck stiffness and photophobia. A CT scan of the brain is obtained, and the radiologist reports blood in the subarachnoid space. This finding is characteristic of A. Ischemic stroke. B. Epidural hematoma. C. Subarachnoid hemorrhage. D. Intracerebral hemorrhage. Answer, C. Subarachnoid hemorrhage. This question tests your recognition of the classic presentation and CT findings for a subarachnoid hemorrhage, SAH. The keywords worst headache of my life, neck stiffness, and photophobia are hallmark symptoms of meningeal irritation caused by blood in the subarachnoid space. A CT scan confirming blood in the subarachnoid space directly points to SAH, typically caused by a ruptured aneurysm. Ischemic stroke involves a clot blocking blood flow, while epidural and intracerebral hemorrhages involve blood clots in different intracranial compartments with different clinical and radiological presentations. Prompt diagnosis of SAH is crucial due to the high risk of rebleeding and vasospasm. Question 24. The nurse is caring for an intubated patient with a severe traumatic brain injury who is receiving continuous propofol infusion for sedation. To accurately assess the patient's neurological status, what is the most appropriate nursing intervention? A. Perform a full neurological assessment every 4 hours while on propofol. B. Briefly interrupt the propofol infusion and allow the patient to awaken for assessment. C. Rely solely on pupillary responses as the most reliable indicator of neurological status. D. Increase the propofol dose to ensure the patient remains deeply sedated. Answer, B. Briefly interrupt the propofol infusion and allow the patient to awaken for assessment. This question addresses a critical aspect of neurological assessment in sedated, intubated patients with brain injury. While continuous sedation like propofol is often necessary, it significantly masks neurological signs, including level of consciousness and motor responses. The most appropriate and safest method to obtain an accurate neurological assessment is to briefly interrupt the propofol infusion, a sedation vacation, to allow the patient to awaken sufficiently for assessment, then restart the infusion. Relying solely on pupillary responses is insufficient, as it only assesses a limited part of brain function, and continuous deep sedation prevents any meaningful assessment. Always ensure you can assess neurological status without confounding drug effects. Question 25. A patient with a severe anoxic brain injury has been unresponsive for 72 hours. The family is considering withdrawal of life support. Which ethical principle is most central to the nurse's role in supporting the family's decision-making process? A. Beneficence. B. Non-maleficence. C. Autonomy. D. Justice. Answer: C. Autonomy. This question delves into the ethical principles guiding end-of-life care decisions in neurocritical patients. The core concept here is autonomy, which refers to the patient's, or their surrogates, right to make decisions about their own medical care, free from coercion. In this scenario, the family, acting as surrogates for the patient who lacks decision-making capacity, is exercising the patient's right to autonomy by considering withdrawal of life support. Beneficence, acting in the patient's best interest, and non-maleficence, doing no harm, are also important but typically guide treatment choices before withdrawal discussions. Justice refers to fair allocation of resources. Supporting family autonomy in these difficult decisions respects the patient's ultimate wishes, even when they cannot express them.